This delayed onset, followed by variable duration, is a normal pattern and helps explain why the first few hours after the injection feel different from the days that follow. Are you ready to get back to what you love after knee replacement? The Total Knee Success Podcast is your trusted guide with practical tips, evidence-based strategies, and no fluff. It's not personal medical advice, just solid education to help you manage pain, regain mobility, and get back to living the life you love. Let's dive in. Welcome back to the Total Knee Success Podcast. I'm Michelle. We're beginning a 4-part series called Before Total Knee Replacement, What Injections Really Do. If you're considering surgery, trying to delay it, or simply hoping to reduce your symptoms, injections are often a part of the conversation. By the end of this episode, you'll understand exactly what a cortisone injection changes inside the knee, what it does not change, and the key factors that just might help you decide your next step. This discussion is educational in nature and is not a substitute for individualized medical advice. Your medical history, imaging, and surgical timeline should always guide decisions in consultation with your orthopedic surgeon or healthcare provider. Cortisone is one of the most commonly used injections for knee osteoarthritis. It's been around for decades. It's familiar. It's often covered by insurance. And for many people, it provides noticeable relief. But familiarity does not automatically equal understanding. Let's start with what cortisone actually is. Cortisone is a corticosteroid, a medication designed to reduce inflammation. When people say cortisone shot, they're usually referring to a mixture of two medications injected into the joint. One is the corticosteroid itself, most commonly triamcinolone acetonide or methylprednisone acetate for large joints like the knee, and sometimes betamethasone. These are long-acting anti-inflammatory medications designed to calm inflammation within the joint lining. The second component is typically a local anesthetic, such as lidocaine or bupivacaine. This numbing medication works within minutes and often provides noticeable relief for several hours. Lidocaine typically lasts 1 to 3 hours, while bupivacaine may last somewhat longer. That immediate improvement does not come from the steroid itself. It comes from the anesthetic. The corticosteroid works differently. It does not provide instant relief. Instead, it begins reducing inflammatory activity over the course of several days. Many people notice improvement between 48 hours and 1 week after the injection. The duration of benefit varies, but when relief occurs, it often lasts several weeks and sometimes a few months. This delayed onset, followed by variable duration, is a normal pattern and helps explain why the first few hours after the injection feel different from the days that follow. So a cortisone injection does not regrow cartilage. It does not reverse arthritis. It does not rebuild joint surfaces. What it can do is reduce inflammatory activity inside the joint, which can decrease swelling and lower pain levels for a period of time. For some people, the relief is noticeable within a few days. For others, it may take a week to feel improvement. The duration of relief varies. Some individuals report benefit for several weeks. Others may experience symptom reduction for a few months. And for some, the response is modest or short-lived. The variability is important. Cortisone is not a predictable long-term solution. It is a symptom-modifying intervention. In its 2021 Management of Osteoarthritis of the Knee, non-arthroplasty, which means not replacement, clinical practice guideline, the American Academy of Orthopaedic Surgeons states that intra-articular corticosteroid injections could provide short-term relief for patients with knee osteoarthritis, and the recommendation strength is rated as moderate. That short-term framing is intentional, short-term symptom relief, not structural restoration, and not long-term disease modification. A key distinction in this series is the difference between symptom modification and structural change. Symptom modification means reducing pain or inflammation without altering the underlying joint degeneration caused by osteoarthritis. Structural change would mean rebuilding cartilage or reversing joint damage. Cortisone falls firmly into the symptom-modifying category. So when might cortisone be helpful? Cortisone can be particularly useful during inflammatory flares if the knee becomes acutely swollen, warm, and painful. Reducing inflammation can improve comfort and restore a degree of mobility. That temporary reduction in pain may allow you to participate more fully in physical therapy, strengthen surrounding musculature, and maintain activity levels. That benefit can be meaningful, but pain reduction does not automatically equal improved capacity. Reduced pain gives you an opportunity. It does not replace strength. However, repeated injections require thoughtful consideration. Research suggests that the magnitude and duration of relief may diminish with repeated use. At the same time, while occasional injections are generally considered safe for many individuals, frequent injections raise questions about potential cartilage effects and systemic exposure. In a 2017 randomized controlled trial published in the Journal of the American Medical Association, patients receiving triamcinolone injections every 12 weeks for 2 years demonstrated greater MRI-measured cartilage volume loss compared to saline, without a sustained difference in pain outcomes. More recently, a 2023 systematic review and meta-analysis evaluating longitudinal imaging outcomes found higher odds of cartilage structure worsening following intra-articular corticosteroid injections. In 2025, a longitudinal MRI-based study using osteoarthritis initiative data also reported an association between corticosteroid injections and greater whole joint structural progression over 2 years compared with matched controls. These findings do not mean that a single injection will cause meaningful structural harm, and it's also important to recognize that osteoarthritis progresses over time regardless, and imaging progression does not always translate to a difference in surgical outcomes. However, they do support being intentional about repeat injections and ensuring they are tied to a clear functional objective. That's the therapist coming out of me. For most people listening, this information is not a reason to panic. It's simply context for thoughtful decision-making. Current clinical guidelines vary slightly in their recommendations, but many recommend limiting the frequency of corticosteroid injections in a single joint. The goal is not to eliminate cortisone as an option, but to use it strategically rather than reflexively. There's another important consideration when cortisone is used before total knee replacement, and that is infection risk timing. Several studies have examined whether receiving a corticosteroid injection too close to the time of surgery may increase the risk of post-operative infection. And while findings vary, a consistent theme has emerged in orthopedic literature. Injections administered within a short window before surgery may be associated with a slightly increased risk of periprosthetic joint infection. Because infection after total knee replacement is a serious complication, many surgeons recommend avoiding corticosteroid injections within a specific time frame before surgery, often around 3 months, depending on surgeon preference and individual risk factors. The overall risk of infection after total knee replacement remains low, but because the consequences are significant, surgeons tend to be cautious about modifiable risk factors. The research in this area continues to evolve. Some studies suggest the highest infection risk occurs when surgery is performed within 4 weeks after an injection, while others support a longer 90-day window. In clinical practice, I've noticed this. There appears to be an increasing caution when injections are being considered close to a potential surgical date. That observation likely reflects growing attention to infection risk and long-term surgical outcomes. For that reason, this timing discussion should always happen directly with your surgeon, obviously. Your health profile, your surgical timeline, and your surgeon's interpretation of the current evidence all influence what is safest in your situation. If you're considering surgery in the near future, this timing discussion becomes central. Now let's talk about what cortisone does not change. It does not slow the progression of advanced osteoarthritis in a predictable way. It does not restore joint space in a severe bone-on-bone arthritis. It does not eliminate the mechanical forces created by joint deformity or significant cartilage loss. If your pain is primarily driven by structural degeneration rather than active inflammation, the magnitude of relief may be limited. In advanced bone-on-bone arthritis with significant deformity, the magnitude of relief from corticosteroid injections is often limited as well. This is where clarity becomes essential. Some individuals interpret short-term relief as a sign that the joint is healing. In reality, the medication is calming inflammation, not rebuilding tissue. And that distinction shapes expectations. A thoughtful approach to cortisone involves asking questions. Here are 3 types of questions to consider. First, what is my goal? Is the goal to reduce pain during a temporary flare? Is it to improve comfort for a specific event or travel? Is it to delay surgery for logistical reasons? Second, where am I in the surgical decision process? If surgery is likely within a few months, timing becomes a priority discussion. If surgery is not yet scheduled and you're exploring conservative options, a cortisone injection may serve as a bridge while strengthening and conditioning continue. And third, how has my knee responded in the past? If previous injections provided meaningful relief that allowed you to function more comfortably, that history informs future decisions. If prior injections produce minimal benefit, repeating the same intervention may not produce a different outcome. Cortisone can also influence activity levels. When pain decreases, people often increase activity, and that can be positive, particularly if increased activity includes structured strengthening and movement quality work. However, if activity increases without attention to mechanics or strength, symptoms may return once the medication effect fades. Temporary relief can feel encouraging, and when symptoms return, that can feel discouraging. Understanding that pattern ahead of time can prevent that emotional whiplash. The long-term success of total knee replacement is influenced by overall conditioning, strength, and mobility entering surgery. If cortisone provides a window of reduced discomfort, using that window intentionally can be beneficial. There are also systemic considerations. Corticosteroids can temporarily elevate blood sugar levels, which is particularly relevant for individuals with diabetes. If you have diabetes, it's important to discuss glucose monitoring with your healthcare team after an injection. No intervention exists in isolation. So where does cortisone fit within the broader picture of preparing for total knee replacement? It can be a short-term tool. It can be a bridge. It can be a way to reduce inflammation during a flare. What it is not is a cure for advanced osteoarthritis. A 2025 longitudinal systematic review emphasized that improvements in physical function define success for many individuals undergoing knee replacement. Pain reduction is important, but functional capacity carries equal weight. If cortisone helps you maintain walking, strengthen effectively, and remain active, that aligns with long-term goals. If cortisone does not meaningfully improve function or quality of life, then it may not change the overall treatment trajectory. And that's not to diminish the benefit of having some pain relief, but this really is a benefit versus risk discussion. And this is not about being for or against injections. It's about alignment. Alignment between your goals, your surgical timeline, if there is a surgical timeline, and the biological reality of what cortisone can and cannot change. In some cases, individuals receive multiple injections over several years while symptoms gradually progress. For others, one injection provides sufficient temporary relief during a specific period of life transition. Where you are in your overall process shapes whether this makes sense. When you speak with your surgeon or referring provider, consider asking, how long should I wait between an injection and surgery? How many injections are considered reasonable in my case? What outcome should I realistically expect from this injection? These questions move you from passive recipient to informed participant. As we move through this series, you'll notice a consistent pattern. Each injection type will be evaluated through the same lens. What does it biologically do? What does it actually change? What does the evidence show, and where might it fit appropriately? Cortisone sets a foundation because it's the most familiar option. It reduces inflammation, it can reduce pain. It does not reverse structural degeneration. Its timing relative to surgery is important. If you choose to receive a cortisone injection, monitor your response carefully. Notice not only whether pain decreases, but whether walking quality improves. Does stair descent feel more controlled? Can you participate more fully in strengthening exercises? Does swelling decrease in a way that supports mobility? If swelling decreases after the injection, that can create a window to improve range of motion, and these functional markers are more informative than just the pain scores alone. If relief occurs, use that period intentionally. Continue strengthening your quads, maintain hip stability, preserve walking capacity. The goal is not simply feeling better for a few weeks. The goal is positioning yourself well for whatever comes next, whether that is continued conservative management or eventual surgery. If relief is minimal, that information is equally valuable. It may suggest that inflammation is not the primary driver of your symptoms, and that mechanical degeneration is playing a larger role. Clarity generally reduces frustration. And before we close, I want to emphasize something important. Deciding to receive or decline a cortisone injection does not define your commitment to surgery or your resilience. It's simply one decision point along a larger pathway. In the meantime, if you're considering cortisone, approach it with clear expectations. Understand what it can change and what it cannot. Let the decision align with your timeline, your goals, and your overall preparation strategy. And remember, your preparation, not just the injection, influences what comes next. If you're preparing for surgery right now, this is where I want to briefly mention something. Preparation is not only physical, it's educational. Understanding what to expect, how to approach the week leading up to surgery, and how to position yourself well going in can influence how steady and confident you feel. My upcoming book, The Knee Replacement Game Plan, provides educational content designed to help you prepare for surgery and ask informed questions so you can approach the process feeling steady rather than overwhelmed. You can find more information about it in the show notes. In the next episode, we will examine gel injections, also known as hyaluronic acid injections. These are often described as lubricating the joint or improving joint fluid quality. We'll look at what the description actually means, how the evidence compares to cortisone, and what realistic expectations should be before total knee replacement. Injections are tools, not solutions. The more clearly you understand their role, the more deliberate your decisions become, and deliberate decisions shape better long-term outcomes for your knee and for you. I'm Michelle, and this has been the Total Knee Success Podcast. This podcast is for educational purposes only. Discover more at totalkneesuccess.com, and be sure to subscribe and share, because every step forward takes you closer to living the life you love.